Yeah, there's been a lot of talk, the industry, medical device companies. So, this is specifically reconstructed total hips and knees, revisions, things like that. There's been, the industry is having a tough time, forecasting the needs, right? I mean, how many sets of instruments are we going to need to have? How many implants are we going to need? Technology such as ours, there's going to be needed. Do you see a resurgence in this going forward? Do you see that there's going to be just this, huge volume of orthopedic elective cases that's going to happen, end of Q3, Q4? Or do you believe it's going to be something that's going to be more of a staggered, slower kind of ramp up?
I think that's, I think the patients are going to be there, no doubt. By putting off all these cases, there's going to be, by definition, a backlog that need to be taken care of. There's no question that there's going to be potentially a huge flood of patients and cases that need to be taken care of. The deciding factor is going to be the hospital systems that are allowing these cases to be done, whether or not they just open their doors 100% versus doing this stepwise gradual kind of increase, which my suspicion is that they're going to take the more stepwise gradual increase to their caseloads. I don't think any major hospital system wants to take the risk of just opening their doors saying, hey, we've got enough resources, let's get going. Although I can tell you from discussions with all the different systems, they would love to do that, but I can guarantee you none of them want to make that leap of faith, so to speak, to take that jump and say, we just need to get going. So they all want to be cautious about their slow reintroduction of the caseload.
Yeah. So we have a question from the audience, Urshad Shakir. My question is about the second hit phenomenon, right? Once there's a decrease in COVID patients and we open back up, people leave quarantine, there will be an increase in COVID cases. There has been talk about phasing in at 2-week intervals, i.e. work for 2 weeks, a different team works for 2 weeks to keep resources fresh. Is this something that can be possible with joints, you think?
So, speaking as, I would say, a layperson in terms of the COVID and level of that COVID expertise, but being an orthopedic surgeon and whatnot, but I've definitely done some research about what else is going out there in the world, and the places that have reopened doors, so to speak, to business in terms of just general access to the business, but also in the health field. There has been evidence of resurgence, however, not to the extent that we first saw. And it's very interesting in that all the predictions have been way higher than anything that's been actually seen. So every outcome in terms of COVID patients, in terms of rates and fatalities, all those numbers have been down adjusted every week as we've been going along. And I have no doubt that in terms of our fear of a resurgence with the second wave after doors are kind of reopened, I've got to think it's going to follow the same kind of pattern in terms of downgrading, or our initial fears and all of our efforts to control are going to be super high. But as the weeks go by, those numbers are going to tick down.
No, agreed. So we have another question that came in. This could be for anybody on the call. Okay, it doesn't always have to be for Dr. Sasaura. And this one may be just for anybody who can answer this. Has there been any qualifying tests discussed for those of us, this is reps, who are going to be re-entering the OR? So anybody have any, if you want to, feel free to talk, please unmute your phone. Has there been any discussions of any hospitals or facilities that are any requirements for testing for reps re-entering the OR?
Sounds like not yet.
Not yet, yeah. Anything from your end, Dr. Sasaura?
Well, it's very interesting because the one of the other items that have been heavily covered in terms of reopening doors to surgical cases is this concept of testing. Testing right now, there's antigen testing, which is a PCR test for the COVID RNA. The problem with the PCR antigen testing is one, it can remain positive for a good month. So the problem is if you're only infectious, and the studies have shown to be infectious for a couple of weeks, then we're over quarantining people based on a positive test. The other possible problem with the current testing, the antigen testing, is the false positive rate. The PCR test is super sensitive. It's oversensitive, and it detects both viable and non-viable viral RNA. So the problem is you can't have non-viable RNA in your system because you were exposed to it previously, maybe you're past it, but you can still come up positive when you don't have any active antigen in your system. So there are limitations to what the antigen testing can do for us. The gold standard, I think, ultimately is going to be the antibody testing, which is still being developed. We still don't have that fully available to the population. But antibody testing, the one problem with it is it means we've been exposed. It means we've created antibodies in our system, but it doesn't tell us yet if that confers immunity, and it doesn't say does it confer immunity for how long. So there are definite real limitations to what testing can and can't do for us. But CMS guideline for reintroducing surgical cases, the OR, says, and they're very vague in their verbiage, but they just say robust testing, patients and hospital staff. So robust testing, take that as you will. I literally had a conversation with the administration at Sutter last night, and that was a heated debate. Robust testing, does that mean once a month? Does that mean once a week? It's just, again, we are coming up with new policy to treat a brand new problem that we've never faced before. And it's going to be very difficult to come up with a policy that everyone can agree with, that's neither too restrictive or too vague in terms of what recommendation we should follow. But these are decisions that are being made right now, looking towards the next 2 weeks for possibly reopening.
Yeah. So another question that came in, Dr. Sasaura, this can be for you, and any other surgeons that are on the line can answer this as well. What percentage of the doctor's total joint arthroplasties were outpatient? So let's take your caseload, for example. And do you feel that that percentage will increase moving forward? So going into the ASC, right? There's been talk about, safer surgeries on total joints, total hips, knees being done in the ASC versus the hospital. What has your percentage been during this? What do you perceive after? And do you see it as a trend that's going to take place going forward?
I think that's a great question. I think this is a trend that we have been seeing increase even before the COVID problem. So I started doing outpatient total joint surgery in an outpatient setting, ambulatory surgery center 4 years ago. This is my 5th year now. But prior to me jumping on that bandwagon, I had watched and considered it for 4 years, where other people were just starting to do outpatient total joints on a more regular basis. So I was kind of a middle latecomer to that party, but have been steadily increasing my percentage of outpatient cases. It's probably about 20% outpatient currently. I have no doubt, and as always, once you start getting more comfortable, more efficient with what you're doing, the indications seem to expand. And it's certainly been true with my own practice. I think absolutely, without a doubt, this whole situation is going to drive patients to the outpatient center. One, because outpatient surgery centers are going to be opened up before inpatient ORs. So that factor alone is going to drive patients to the outpatient setting. But two, just the systems that are involved. I think the familiarity, and the efficiency and effectiveness of our ability to take care of patients, total joint patients in the outpatient setting, has just grown leaps and bounds over the years. And I think that trend is going to get way pushed to the right. And from a patient standpoint alone, I've got to think patients have it really high in their mind in terms of, gee, if I can have my surgery done in an outpatient center versus going to the hospital where, like we've told these patients year after year, that's where the sick people are. I think once that concept really starts to sink into the general population's mind, I think the shift towards outpatient surgeries, particularly for total joint surgery, is just gonna increase exponentially.
I'd agree with you. And our office, as well as other companies across the board, other reps we've talked to, they're really trying to figure out ways to cater to the ASC, especially after this, because they're foreseeing it too. So this is a message to the industry, right? To say, hey guys, make sure you cater to the ASCs, and packaging whatever you can, some bundles or whatnot that will be beneficial to the ASC customer. I had a question come in. Let's see. Some of my surgeons have had to close shop and furlough their staff during the COVID crisis. What are thoughts on utilizing tools in telemedicine to bridge the gap to engage with patients and also possibly bring in revenue to the practice to support the furloughed staff? My docs are concerned. So have you been using telemedicine? Have you been doing any kind of telehealth calls with your patients and, coding office visit charges for that?
So we have certainly we've utilized telehealth technology in our practice, and it's obviously grown exponentially during this crisis now. But we're still talking 5% or less of our office visits are done by telemedicine. If you're specifically talking about joint surgeons, we're generally talking about older patients, and I can tell you with personal experience, when you have an older patient using a laptop trying to do a telehealth video conference, and you ask them to show them your knee, and how it moves, it could be a debacle. It's very difficult to do. So I don't think the technology is quite there yet. And in terms of reimbursement is a fraction of what it needs to be for it to really be successful for private practice. It's just not there. There are systems that have opened their doors to telehealth in terms of reimbursement. But again, it's just a fraction of what you can do on a regular visit. So that remains a problem.
Well, I know that CMS recently kind of lifted up some of the restrictions on HIPAA compliant telehealth systems. So patients could use Zoom or Skype to talk with their physicians because not everybody has those specific platforms, right? Are you using those yourself, or do you have specific platforms that are already baked into your hospital systems?
We're using Zoom. It's a very simple system to use. So we've been using Zoom for telehealth visits. It does fall under HIPAA compliance, and we're okay in that standpoint. And you have to think that, again, with a crisis like this, once we get on the other end of it, you got to think telehealth is going to be a much bigger deal and more widely accepted and pushed from a CMS standpoint. It just makes sense.
Oh, absolutely. So I have another question here. And again, this could be for the group, anybody else that wants to chime in. Many reps are concerned hospitals and ASCs will try to further drive down implant pricing even more due to the shortfall in revenue. How much does price and value matter in the post-COVID environment?
That's a great question, and that's going to be a guess. There's really no way to know for sure which way it's going to go. But the trend has been more and more fighting in terms of pricing, implant pricing, and whatnot. From the ASC standpoint, certainly from hospital standpoints as well. For whatever reason, they come to think that the implant price is the end all be all in terms of lowering cost for the overall cost for a total joint, say. It's actually a fraction of what we're talking about in terms of the overall cost. There are many more factors that are involved that are, in my opinion, more important and more pressing in terms of controlling to get that cost down. But there's no question that hospital systems, ASCs included, are going to take advantage of this current crisis to try to drive their agenda to really kind of wring it out of the implant companies to try to decrease what the cost that they're seeing. But we'll have to see. The other issue is the reps. There's always a question of like, gee, what are hospital systems going to do in the future in terms of having reps? Are they going to let these? Are they going to let reps continue to be a part of the surgical suite in terms of taking care of patients and whatnot? That's a separate amount of cost that kind of factors into this. But obviously from a surgical standpoint, that particular part of the cost is invaluable.
Oh, for sure. And yeah, I think hospitals are recognizing a decreased revenue during this. There's no doubt about it. And there's been talk about especially hospital and accounts capital expenditure budgets. That those are going to be hit very hard. Hospitals aren't going to be as likely to necessarily invest in large capital bringing into their systems for quite some time. The argument to that is, well, that's not true. Some of this capital, such as robotics and whatnot, may be valuable to the surgeon to help, with their outcomes. Now, this question is for the group. Dr. Sasaura, please, answer this too. But I mean, do you foresee? I mean, has your hospital system kind of restricted you on what you can bring in as far as capital expenditures in the hospital or ASC?
So when you're talking about capital expenditure, that's a huge hot topic in terms of any conversation with administration, regardless of what system you're working with, particularly in the ASC, where cost control tends to be a lot tighter. And oftentimes, in my case specifically, we're talking about some private investment or involvement in the actual center. When it comes to capital expenditure, that's the bottom line. That's a big deal. And of course, with hospital systems, they're not gonna willingly open their purse books for any notion that we can do things better by expending X, Y, and Z. What they want is proof in the pudding. I have personal experience and no doubt that certain capital expenditures are blatantly obvious in terms of, one, improving patient outcome, but two, helping hospital systems do better. If you're using the technology that everybody wants and theoretically everyone needs, that's going to be a win-win. The surgeons are going to do a better job and the patients are going to get better outcomes. And on the flip side, hospital systems can do better by increased volume. So, I'm sure it's a multifactorial answer. But the bottom line is, when capital expenditure makes sense, then it's a win-win, and that just has to be communicated with administration in the right situation.
Sure. A question from Joe, and this is unsolicited. Does Dr. Sasaura utilize OrthAlign in his ASC?
So that's a great question. OrthAlign is, in my opinion, the answer is yes. OrthAlign, in my opinion, is ideal for the ASC setting. One, it's still an open platform system. So if you have multiple surgeons doing cases, OrthAlign can be utilized by everybody, no matter what system they're using. So that's super helpful in terms of availability. Cost-wise, there is no capital expense. It's a case-by-case basis. And
Dr. Sasaura, are you still there? I think we may have lost you. Dr. Sasaura? So we may have lost temporarily Dr. Sasaura he'll get back on. It looks like his wireless connection was struggling a little bit there. But when he comes back on, he'll finish his commentary. But what I would like to do is maybe address a few more questions until he gets back on. So this question came from the audience member. We mentioned robust testing earlier. So this question is in regards to the testing that reps would need to go through in order to be admitted into the operating room. How do you think that test will be paid for, and is that passed to the vendor? So I have heard some grumblings through vendor mate rep tracks about, it's going to be based, on each facility and what their requirements are. So basically a local decision. But I do expect that RepTrax, VendorMate, and other vendor credentialing services will probably add, something to do with testing as we go forward. That you're going to have to show that you're not, number one, not showing any symptoms when you enter the operating room by way of taking your temperature. But also you may have to go undergo some testing. We just don't know what yet.
Here we go. I made it back. Sorry.
All right. Perfect timing. Go
Sorry,
ahead.
we were talking about OrthAlign. The short answer was yes, I'd use OrthAlign in the outpatient setting, and I was going on about, I think it's ideal. It's an ideal system for the outpatient setting, particularly that it's an open platform system. So if you have multiple surgeons at the ambulatory center using different systems, they can all use OrthAlign and still get the benefit of computer navigation, regardless what implant system they're using. So that alone makes it an ideal system. The second thing is that there's no capital expense with OrthAlign. It's charged on a case-by-case basis, which is, again, is an ideal situation for any ambulatory care center. So I think it's a great system. It's super helpful and accurate. I use it on hips and knees, but particularly I think it's great. It's ideal for the outpatient ambulatory center.
Perfect. Thank you. Some more questions.
That was unsolicited.
Yeah, that was actually an unsolicited question. I didn't know who that was, but thank you for the question. Are there any concerns with instrument prep and space for total joints in the ASC sterile processing area? This is a good question because we know that if you have limited space here, how will that affect ability to perform the desired or needed case volumes in the ASC? It's a good question.
Yeah, so that not every ambulatory care center can handle doing total joints. I mean, you're talking about specifically on the sterile processing side of things and case volume. So your ability to do multiple cases in a day can be affected by the ability to handle sterile processing on the back end. On the front end, if the operating room itself isn't big enough to handle that kind of a case, that's an issue. If you don't have staffing that's familiar with total joint surgery, that could be an issue. If you don't have anesthesiologists that want to do blocks, that could be an issue. There's so many issues involved with being successful at doing outpatient total joint cases. We've had the good fortune of having to build centers with joints and spine cases in mind specifically. So we've tailor-made our centers for those particular cases. But absolutely on the back end, on the sterile processing side, you have the ability to turn over instruments to get multiple cases done. So if you have an existing center, it can certainly affect and limit the number or even the ability of types of cases you can do. But those things should be considered heavily when you're talking about opening a new center for those specific kind of cases, total joints.
Yeah, and I agree with you. I don't think all ASCs, it just depends on how they are set up. But also too, that surgeons that want to migrate from the inpatient or outpatient hospital setting to an ASC, that's a big change. There's a lot of differences, and they have to be educated on how to do that when it comes to what anesthesia to use, what's available, what's the pre-op protocols, what's the pro-op protocols, rehab. So I know it's a much grander thing than just walking out of a hospital doing joints and into an ASC. Where they have to adjust to, right? What I like to do is I'd like to open up some questions of our own to the audience members. And what we do, Dr. Sasaura and I would kind of like to know what's going on in your area. So is there anybody on the line that can tell us what's going on in their part of the country? This is all geographically affected, which means, it's different in every geography. Some places are affected more than others. Some are returning to elective cases sooner than others. So like to hear from someone in the audience and let us know what's going on in your area. What are your concerns? And let's get this discussion going. So if you have a question, please unmute your microphone and go ahead and ask the question. We'll give you a few seconds to do that or comment.
Hey, this is Chris Simmons. I'm based in California, and I appreciate you guys hosting this. And the feedback has been fantastic.
Thank you.
What we're seeing kind of in our environment is it's continued lockdown with hints of a gradual release of restrictions. for elective ortho surgeries and engagement with the patients, the clinician and the patient. So it's still kind of, we're all pent up over here, and a lot of us aren't able to do what we do outside of trauma surgeries and things like that. But I did have a question that I'd like to throw out to the group. We're getting hints that the restrictions will slowly be reduced and potentially a phased cadence. And I recently came across some information on the CDC website about phase 1, including outpatient surgeries being released first, and then in phase 2, outpatient, inpatient procedures being opened up essentially as they move through this process. What is your thought on day 1 after they open this up? And this is just throwing it out to the group. Dr. Sasaura, you had mentioned that you're going to be kind of fighting over OR space, and you alluded to capacity and throughput issues inside of ASCs and hospitals. I'm curious on everyone's expectation and thought on day 1 after they open up inpatient and outpatient surgeries, what that environment's going to look like for hospitals and orthopedic providers specifically.
Thank you for that question and comment, Chris. Does anybody have any comments and potential answers for Chris on what they're thinking and what they're seeing in their area? If you do, please unmute your microphone. While we're waiting, I will say, Chris, that in Texas, so I'm in Austin, Texas, it is absolutely based on what it's the local decision makers that's making the decisions on how they're going to do this, right? So Governor Abbott has basically said we're supposed to postpone all elective non-essential procedures, right, which includes hip and knee procedures, total knees and total hips, until May 8th. And if we're going to do any before then, there's some guidelines that we're supposed to follow. But again, that's left up to basically the practitioner, which is the surgeon and the patient, and their decision making as they're speaking. So I think protocols are probably going to be developed as we go, because we just don't have anything that's really canned. We have a lot of guidelines that's been put out by the AORN, the CMS, CDC, even President Trump put out some guidelines for us. But it does, to your point, Chris, it does seem that we're going to be going to the ASC first because it's perceived to be the most safe. It's not a hospital where, a lot of people with true illnesses, influenza-like illnesses or comorbidities are going to be, it can be a little bit more controlled. So that's the reason why there. But as far as what it looks like, from what I've read, and to prepare for this, I did a ton of reading and all, what's expected. And there is expected to be, that each facility, when they do start doing elective procedures, are supposed to have at least 25% of their facility opened up for COVID patients. And they're supposed to separate the COVID from the non-COVID patients. You're supposed to have enough PPEs, enough, like what Dr. Sasaura said, ventilators, ICU beds, and staff. Now, the staffing can be an issue. Right now, our staff they're working like crazy. So, are you going to have enough staff to rotate through without being just absolutely exhausted? Because we know that exhausted healthcare professionals can make mistakes. So they're wanting to make sure they have enough staff. That's not only nursing and surgeon staff, that includes pharmacy, that includes housekeeping staff, SPD, anesthesia, all the important, departments that are needed for each case. So there's going to have to be an internal assessment of what their capabilities are. And if a facility feels like it does not have the capabilities to have the surplus in PPEs or the bed space to accept another surge of COVID patients, then they're expected to postpone their non-essential cases. a little bit longer until they do. But for facilities that do have that, then they're allowing them to do it with those guidelines in place. Dr. Sasaura?
You know, and to that point, I'm going to respond to that.
Yeah.
This is Chris. I think that a lot of the expectation amongst, you know, the sales community in this industry, and, you know, surgeons and clinicians in orthopedics specifically, think that, you know, once this is lifted, everything will be okay, and we'll go back to the normal environment that we lived in. And to the points that you mentioned and that have been brought up in this call, what I've been thinking about is the potential for throughput issues. And ASCs are absolutely going to see a tremendous increase in utilization for outpatient and things like that. But ASCs typically have a very small amount of ORs relative to a hospital. So their ability to physically, you know, have a throughput that is equal to what was normal in hospital is going to be a little bit smaller, but it's going to be maxed. It's going to be nonstop, which is fantastic. In hospitals, to your point, you know, they see the patients that are sick with COVID and have been, you know, either in the ward or are currently in the ward. And that section of the hospital, to some extent, may be quarantined, depending on hospital quality or, you know, policy, if you will. You know, that's going to be quarantined. So somebody that comes in is able to get a knee replacement, when they get wheeled out of the room, they're not going to go to that floor. So there's a limited capacity in that extent. Mm-hmm. So it's a gradual throughput issue that we're going to have to, over time, you know, just kind of get back to normal, clear out, you know, people and put them on the boats in New York, whatever, that are doing the, you know, the hospital Navy things. So we can open up the capacity of these hospitals that have been seeing these patients. Day one after the opening of the floodgates doesn't mean return to normal. And, you know, I've talked with a few surgeon friends of mine, and they are throwing out years before we fill the backflow of all the patients that have built up and all the patients that continue to build up on an average basis in orthopedics that need care. It's going to take years to get back to normal and have a steady flow, not to mention the time it takes to get the hospitals cleared to return to normal capacity. So I wonder what, you know, from a surgeon perspective, you know, Dr. Sasaura, what you're thinking, if you agree with what I said, you know, what you're thinking, because this is essentially is extending the time of delay to get back to normal. What are you thinking in your practice, and how are you circumventing, you know, a continued delay of turning the lights back on?
Yeah, I think absolutely. I think we talked about that before, the fact that everyone's talking about lifting the restrictions. And again, Governor Newsom literally just stating that he's lifting restrictions on essential surgeries in California. But just because that switch is flipped, it does not mean things are going to flip back to normal instantly. So I agree with you absolutely 100%. That's not going to happen. And again, hospital systems are struggling with putting policy in place, making up brand new policy to say how that is going to look in terms of prioritization and percentage of what I talk about, the velocity of returning back to normalcy. I'm hoping and thinking it won't be years before we get back to a more normal schedule. I think hospitals are too, what do I say, too financially driven, honestly, to be able to put up with that for that duration of time. So they're going to find ways to make this happen. So somewhere between instantly and years is my suspicion that we'll get back to normal. Personally, I'm thankful we have, you know, I've got the capability of doing cases at a standalone, you know, independent surgery center where I can do ASC cases outside of the quote hospital system, where we have more control of how fast we ramp up. Again, there's really no right or wrong answer, or how aggressive or conservative to take this approach. We're writing policy as we go. The big issue of testing is a big question mark right now. One of my reps had texted me a question about virus testing before for our patients in the ambulatory setting. You know, we're currently not requiring our patients to be tested. We're strictly going by symptomatology, but basically treating everyone as if they're positive. So taking every PPE precaution. You know, during intubation, extubation, there's only one person in the room. That's the anesthesiologist. They've got extra protection in terms of equipment. You know, getting these patients out of our center is as safely, as quickly, but as safely as possible. So those are things that are directly under our control that I think are going to be able to let us do more in our ambulatory care setting to hopefully offset what we're not being able to do in the main hospitals. But it's going to be a hard, slow, you know, battle to get back to our normal kind of volume. There's no question about that. But I'm hopeful we're definitely not looking at years.
Perfect. So we have a few comments. You know, we had asked, you know, what's going on in your area. So we have a few comments that came in, kind of letting us know what's going on in some of these areas. So we have one, rural area hospitals along with ASCs look to be the first to open, which we've been talking about. So this Southwest Colorado will be starting cases next week with a 50% capacity for the first 2 weeks. The larger IDNs here in the Midwest have set dates that tend to follow what the state's governor has set, which that makes sense. A larger IDN in Wisconsin has segregated recon cases to centers that have not had COVID cases reported in the last 30 days. Those COVID centers will be reintroduced to electives gradually as they clear out those COVID patients.
Right.
So that's interesting to hear what's going on in the Midwest and Colorado. Also in Colorado, we have a comment. Mark says that here in Colorado, surgeries will open back up on the 27th. No patient over the age of 65 will be allowed at this time, which that's pretty interesting. Is that just because, Dr. Sasaura, you think just because they're vulnerable?
That's exactly right. I mean, there's really different you know, approaches, different kind of strategies that a hospital systems are going to use to reopen their doors. Some are making it simpler as, you know, well, if we're going to do cases in the inpatient setting, they're going to be ASA 1 and 2 only, which is what you're going to do with the outpatient setting only, normally, regularly anyways. And then later, as these cases progress and COVID patients continue to decrease, then start allowing more ASA 3 and 4 kind of patients to be done. So again, they're trying to limit risk of patient exposure, particularly the patients that are more vulnerable.
Okay. So from Sandridge, in Western North Carolina, we will open back up on April 27th as well. Only the patients will be allowed into the hospital. Once finding this out, several patients have decided to postpone their joint replacement until their spouse family will be allowed in. That's interesting.
That is interesting. They implemented that pretty quickly, even for trauma cases that are being done right now. No real family members visiting, even for the acute care kind of cases that are being done.
Yeah.
Which I think, again, we're limiting exposure to make sense. But absolutely, and you know, that's been kind of our approach from our own ambulatory care centers. You know, if a patient, and this is part of our consent now, you know, we actually consent our patients about, you know, hey, we are continuing to do these cases at our ambulatory care center. You know, we have 0 COVID patients because we have no inpatient population at all. But there's an unknown amount of risk that you, the patient, are taking, and we, the staff, are taking in terms of exposure to get these cases done. So we're, you know, if a patient is interested in proceeding with surgery, you know, they've got the proper support in place and whatnot. They want to have their case done. They understand the risk involved. We're proceeding. We've taken that stance since this all started at our own ambulatory care centers. Now we have definitely decreased our own volumes. We've limited the number of days. We've been only operating 2 days out of the week at our center, running one room at a time only, and again, taking all the precautions that I mentioned earlier on the case-to-case basis.
Okay. So this one, this conversation, we have a lot of reps on the line. A lot of reps have a lot of questions about what their role is going to be going forward. What's going to be the expectation from them, from the surgeons and from their accounts. So for the surgeons on the call, do you see some hospitals and ASCs limiting rep access due to safety concerns? If so, do you think surgeons and OR teams are prepared to run cases solo if reps aren't allowed in cases temporarily? So anybody want to comment on that? Any other surgeons on the line that may want to comment? Or anybody else?
Yeah, I'd be curious to see what other people are thinking and talking about.
Yeah, same here. Has anybody heard anything from their accounts, either directly or indirectly, where the reps will have restrictions through this pandemic and maybe even after?
Not so much.
Yes, hi. This is Julio Benavidez. I'm out of LA in California as well. And what I have heard is that my primary role as a rep now is going to be as a runner for implants rather than in the room, unless we're having a case that will definitely need me, like some sort of a revision or a very difficult case. But otherwise, it seems that they want to keep the reps from going back and forth from room to room because of the possibility of carrying something from one patient to another. So it's kind of interesting, but they're still trying to figure out how they're going to do that. They'll probably just post me in the substerile core with a phone kind of thing and say, this is what we need. So it'll be interesting to see how it pans out.
So Julio, you're saying that maybe just for primary hip and knee cases, you won't be needed, but maybe for like revisions or some other complex procedures, you may be needed?
Correct. Yeah, that's the bottom line.
Interesting.
So yeah, they are basically trying to just minimize the exposure that I'm going to be bringing from room to room. I'm used to covering 3 and 4 rooms at a time, but because of this whole different scenario, they're just concerned about cross-contamination.
Right. Very interesting. Anybody else have similar experiences so far? I know that there's some elective cases going on, and if you're handling those elective cases, how are you doing it from a rep perspective? Yeah, please unmute your mic and let us know. Dr. Sasaura, while we wait on that, for you specifically, and when you're operating and you're doing your cases in the ASC, or is your rep in the room, for instance?
Absolutely. I think it's going to be a surgeon dependent kind of a situation, because certain cases demand more involvement. Certain surgeons are going to demand more involvement. I think the ability of a rep to help a surgeon from another room is extremely limited. Yeah. I think I have personal relationship with a particular rep that has had that situation at a hospital system where they didn't allow him in the OR. And I just can't imagine a rep trying to talk a tech through a case in terms of the instrumentation over the phone. It sounds impossible. So as far as I'm concerned, surgeons, in order to do their job well, need the proper support and help, of which reps are essential. And I think any conversation with administration to that effect should be well received. You can't do a case without an anesthesiologist. You can't do a case without an OR tech or a circulating nurse. I would argue you can't do a case well without a rep there to make the case go smooth.
So I'd like to throw, thanks, Dr. Sasaura. I'd like to throw this back to Julio. Julio, if you're still on the line, how are your surgeons doing the primary procedures without your help? Or are they using the same techs as a team, the tech that's very familiar with their instruments that knows it backwards and forwards? How are they doing that?
Well, interesting question. I think that that's what's going to become the limiting factor for them, is the fact that currently at that hospital, it seems that they have roving reps. So a rep that's going to be in orthopedics is going to be in general or in eyes the next day. So in this case, the only way that they'd be able to do that is by actually having committed teams to the OR. There are some techs that actually know the instruments a lot better. They require a lot less input from me as the rep. However, that's not the case with everybody. So I think that that's going to be their limiting factor as to how this is going to work out.
Okay, I appreciate that. Thank you.
Sure.
So we have about a minute left of our call. This hour went by super fast. I didn't even realize it was
Yeah, it did.
almost an hour. Before we go though, I want to make sure that, if there's anyone on the line that has any burning questions that, before we go, that you might, maybe someone on the line can answer. Go ahead and please unmute your phone or put it in the group chat. Either way, like to hear from you.
Hey, Chad, this is Dennis Tiza, Dr. Sasaura. Thank you for joining this evening. I do have a question for you, and it's around the pent-up demand and the numerous surgeons that I've spoken with over the past few weeks who said that the typical knee and hip replacement day is going to go from, 6, 7 joints a day to 12, 13, 14 joints a day. One, do you agree with that thought from your perspective out in California? And two, how does that play with fatigue and the value of something like OrthAlign or other technology being a part of these surgeries to give the surgeon that assurance that with the added caseload and the duration of time, the long days, the staff and everything, how that might be a benefit to you and the other surgeons that are on the line here?
So from a personal standpoint, I think I will absolutely utilize anything I can to make my day go more efficient. If I can do 7 cases instead of 6, 8 cases instead of 7, that's a good thing. And I think with the ever increasing demand, regardless of what's going on with COVID-19, the demand for total joint cases over the next 10 years is going to continue to increase. We're going to feel a heavier burden now getting past this pandemic, but regardless of that, there's going to be an increase over the next decade tremendously of the number of cases that are going to need to be done. So anything and everything we can do to make our days more efficient is going to be a good thing. And as an aging surgeon, again, anything that can make my cases go better is a smart move. So personally, technology, I think, is a great adjunct to that effect. Any piece of technology that can help me do my job better, more efficiently, more effectively, more accurately, I'm going to go ahead and utilize. OrthAlign is definitely one of the arrows in my quiver to get it accomplished.
Awesome. Thanks, Dr. Sasaura. Any other questions, comments? All right. Well, we're going to go ahead and close this call. Thanks, everyone, for participating. Thank you, Dr. Sasaura, for getting on the line and helping with this. I think it was very engaging. I think that's what the industry was needing at this point in time, so we really appreciate it. And guys, please stay safe, and we'll see you soon.